Hey, welcome to the Go To Physio Shoulder series. My name is Dave O'Sullivan and I am a physiotherapist that has worked in professional sport with both international and club teams over the last 12 years. And what I want to do in this series is just give you some tips and help you look outside the box, so to speak, to look at the whole body when treating shoulder injuries. So in the first episode of this series, what I want to talk about is some things to keep into consideration when you're rehabbing your shoulder. Now in the coming lesson, we're going to learn a few things, but when I look at the shoulder, now this is going to be the a bit of a Popeye style, okay? But when we look at that shoulder pain, the first thing that goes through my mind when I rehab an athlete or when I rehab a 70-year-old patient that comes into the clinic here is what's not doing its job to cause that shoulder to maybe do a little bit more work. So if we think about this, when I go to lift something up, when I go to pick my kids up, the intent happens always at the fingertips. So these parts of the body are going to need to do something. Now let's just keep it simple here, okay? The bicep and tricep are going to be very, very important to getting a co-contraction at the elbow joint. So just like the hamstring, the gastro, and the quad need a good co-contraction of the knee joint to allow the hip to be successful, we need the tricep, the bicep, and the wrist flexors to offer an ability to co-contract at the elbow joint. If they do their job well, that gives us an opportunity for the pecs and for the deltoid to also do their job. If something's not doing its job, is it possible that the rotator cuff gets a little bit grumpy, gets a little bit painful, it gets a little bit weak? Now that's fine, we can do all the rotator cuff exercises we want, but when the athlete or when the patient gets back into the real world and they have to lift their kids or they have to do something that's going to involve quite a high level of load, and this thing here, or whatever it is, hasn't been addressed, that's usually where I see athletes or patients fail traditional approaches. So what we want to do is we want to build a rehab program based on a rock solid foundation where we get all these things sorted early doors. So by the time we get up to the high level rehab, there is no jokers in the pack that's going to cause your patient's pain to return again or cause them to flare up. So in the coming series for shoulders, I'm going to give you an opportunity to have a look at some of the approaches that we use both in professional sport and private practice. With that said, let's get into part one today, where we look at other considerations in the subjective history that may influence where you're going to look at in the coming series. Again, I want you to take all that good information you learned at university, but I'm just going to hopefully open your mind and stimulate some thought into a few other things that we might need to consider, okay? So the first thing with the subjective assessment with Pete is, again, I want to know his story. I want to understand what caused this potential pain experience or discomfort or whatever he's feeling. And is there anything that may be hidden in that story contributing to cause excessive forces in particular areas? So one of the big things I'm interested in with Pete is I want to see if there's any relationship between maybe the hand, the elbow, and the shoulder, okay? So Pete may say something to me like, anytime I'm lifting my kids up, anytime I'm trying to carry something, anytime I do this or this, okay? So that would be straight away, I'll be thinking, okay, is there anything in Pete's history with his elbow or his hand that maybe he's not generating good torque, which may potentially cause excessive forces or excessive work to be done at the shoulder? Again, I'm just thinking out loud here, okay? Same with the neck. Is there anything in Pete's injury history that may have caused some kind of protective tone or some kind of altered motor adaptations that may be causing the shoulder to do more, okay? Again, I always want to ask myself is, why is that shoulder sore, okay? Are these tissues maybe doing too much, okay? So again, in the assessment, if we see, okay, the traps are overactive or the scapula is winging, again, I just want to ask myself why, okay? I don't want to say he's come to the conclusion he's got a weak serratus anterior, he's got a weak rotator cuff, I need to give him X, Y, and Z. I want to ask myself, why has that happened in the first place, okay? Now, if you're working in rugby union, rugby league, Gaelic football, Aussie rules, etc., there may have been a trauma to the tissues, okay? A trauma, we need to understand, okay, how does the body react to that? Well, there's going to be some motor adaptations straight away. We may have some kind of protective tone around the tissues, we may lose range of movement. But again, has Pete had previous shoulder injuries where the motor adaptations may have not been addressed? And now, 3 months, 4 months, a year later, maybe we're seeing some kind of shoulder impingement, etc., that could have potentially, come to show its ugly head or pay the piper, so to speak, as a result of the motor adaptations from previous injuries. Okay, so again, that's just the way I'm thinking with all these injuries. So when I'm asking Pete questions, again, I'm very, very clear on Pete's story. I want to know the ags and eases, but when I'm asking Pete the ags, I'm thinking, okay, what has to generate torque when Pete actually does that test and it has pain, okay? Then we've got two ways of looking at that. We can say, okay, when Pete generates torque picking something up, okay, in this position, say for instance, is it when he uses his anterior deltoid or some other muscle there, that when that tissue generates torque, that's associated then with this pain experience, okay? So again, that signal from that tissue has gone up to the higher centers, and then that message maybe is being interpreted in addition to other factors as some kind of perceived threat where he's has an actual pain experience, okay? Or we could say, okay, is there some tissue here that's not doing its job, so that maybe potentially that anterior deltoid, for example, is generating excessive torque, okay, or it's doing maybe too much work, and maybe the higher centers are going, you know what, this is doing a little bit too much work for me here, so I'm going to give this unpleasant experience just to let the body know, okay? So again, in order to get rid of that pain experience long term, do I need to get something else in the body doing its job so that the anterior deltoid can function as part of a team, okay? Again, that's just the way I think with all these sports injuries, so just keep that into consideration when you're questioning your athlete about their shoulder injury, okay? So they will be the big things for me. The other thing as well that I'm very, very interested in is apprehension, okay? Because with all the clinical tests, all these wonderful clinical tests that we've been shown in university, the reality is that, especially when you have an athlete that's kind of one day post-injury, if he plays a contact sport, is a lot of these tests will be positive anyway, okay? They'll be sore on a lot of these tests. So we don't get a true clinical picture for a few days until the actual acute pain response and this protective response actually settles down, okay? So that's the other thing. But if the athlete says to me, I feel like it's going to, the shoulder is going to pop out or it's going to dislocate or something like that, then, I would be thinking, okay, tell you what, I'm just going to be extra careful with this and pay a little bit more attention, okay? So again, if there's apprehension of the shoulder maybe about to go, okay, for want of a better word, then I will be taking that into consideration a little bit. But if the athlete's just getting pain in all these tests, okay, then I'm not that worried about it at the moment, okay? If with the 1990 test, etc., I'm not that worried about it at the moment, because a lot of athletes will have a positive pain experience, okay, with these tests. And even if they have some kind of known pathology in the shoulder, the correlation to actually that being the true cause of the pain, it's not the best at times. So we'll respect the pathology, but we won't get too bogged down with it, because when we go through our this way of thinking and we reduce the excessive force maybe placed on other tissues, we can change the pain experience very, very quickly, and we can make a lot of good positive changes. We can give that athlete the confidence to get back out there once we do it in the correct manner, okay? So that's the key here with the subjective assessment. I want to know, especially the wrist, the elbow, any previous injuries, any ags and eases where they may be contributing and maybe not doing enough, okay? I want to know anything going on with the neck. And then I also want to know about maybe stuff where the athlete may be in contact, okay? So again, if the athlete just really struggles in contact with the grip or something like that, or he gets the pain when he's doing a specific, or her, she gets the pain when they do a specific movement, again, is the contribution from the hips playing a significant part with the shoulder, okay? So again, I just want you to open your mind when you're questioning people with shoulder pain. And I just want you to consider the implications of what does that mean? Because what that person is going to tell you, they're going to give you a lot of good information. We have to interpret that information and actually consider what that actually means in real life. Okay, so that would be my overview of the subjective assessment: the wrist, the neck, the hips, going right down to the feet. Okay, if something's not doing its job, is the shoulder doing maybe too much? Now again, we don't want to gear too far away from the shoulder in the first session to a point, okay, because we still have a responsibility to decrease that pain experience, reassure the athlete, and give them the confidence to generate torque in different directions through the shoulder. But at the same time, the ultimate goal of the rehab, as usual, is to spend a good 80% of our time, from my own experience, of actually trying to find the true cause of it. And obviously respect the shoulder, give it that 20%, but don't get too bogged down with the shoulder if maybe the wrist, the elbow, the neck is contributing in some way, so that the shoulder is doing excessive work that's ultimately interpreted as a potentially some kind of threat to the system. Okay, I hope you found that useful. I hope it's just allowed you to maybe look at things slightly different. As always, there's not one way to do things, there's numerous ways, which is the beauty of our profession, but hopefully you found this useful. There's plenty more information at www.thegotofysio.com. Head over there now for even more resources. Now in the next episode, I'm going to have a look at some simple assessments that can allow you to start to make sense of your patient's symptoms and then get to clarity in knowing where to start with either your hands-on treatment or with your rehab exercises. I'll see you in the next lesson.